Continue?
Yes.
I was saying that due to these multiple factors, this leads to a decreased quality of life. And patients suffer from those symptoms despite improvement pharmacological treatments for rheumatoid arthritis. Some randomized controlled trials have been carried out to assess the use of non-pharmacological treatments in rheumatoid arthritis. Treatments such as foot orthoses, therapeutic footwear, or self-care. Those randomized controlled trials have shown to be effective in patients with rheumatoid arthritis. For example, in this study of Novak and colleagues in 2009, where it was concluded that there was a notable reduction of foot pain and improvement of activity in patients with rheumatoid arthritis and the use of foot orthoses. Therefore, it's important to research non-pharmacological treatments in patients with rheumatoid arthritis in terms of reducing disability and pain. In that way, the aim of our systematic review was to determine the effectiveness of foot orthoses in patients with rheumatoid arthritis in comparison with other non-pharmacological treatments in terms of reducing disability and pain, and furthermore, to summarize those results in a meta-analysis. This is the methodology that was carried out. First of all, a search in Prospero to discover if any similar systematic review was carried out, and if not, to register the protocol of our systematic review. Next, a review of the scientific literature was carried out to identify and assess the randomized controlled trials for the current study. The search covered the main databases such as PubMed, Scopus, Cochrane, CINAHL, ENVAS, and QIDEM, and the keywords and mesh terms that were used together with the operators or and were foot, ankle, joint, rheumatoid arthritis, orthosis, insole, and foot orthosis. Inclusion criteria was to be a randomized controlled trial which followed the following PICO question. P from patients, women and men with rheumatoid arthritis, 18 years of age and older, and who presented with foot pain. Studies focused on juvenile rheumatoid arthritis and OR-gate analysis were excluded. I from intervention, to compare between foot orthosis and other non-pharmacological treatments, such as placebo orthosis, which do not treat or make any biomechanical compensation to the patient. C from comparison, other non-pharmacological treatments, such as footwear or another type of foot orthosis. And O from outcome, evaluation of pain and or disability using an appropriate instrument to measure those outcomes. The following information was extracted from each study: author, year of publication and country, type of facility and participants, allocation, concealment method, follow-up period, frequency of assessment, and intervention used. Appropriate instruments were used to measure the results regarding the clinical effectiveness of the foot orthosis, which was the questionnaire of Foot Function Index. The Foot Function Index is a self-administered questionnaire which consists of 23 items divided in 3 subscales, which are pain, disability, and activity limitation, and each item is rated from 0 to 9 in a visual analog scale. This questionnaire has been validated previously in patients with rheumatoid arthritis. And finally, data was extracted and pulled using Redman software. Those were the results after the systematic literature review, which is presented in detail in this Prisma flow diagram. Identified was a total of 180 articles in the databases, as well as 11 additional records identified through other sources, which was a secondary search. Of these 180 items, 104 were excluded for methodological reasons and duplicates. The remaining 14 articles were evaluated by 2 independent reviewers. Of these, 4 were excluded due to differences in inclusion criteria, and 5 were excluded due to the risk of assessment bias. Therefore, only 5 articles fully met the inclusion criteria. Regarding to general characteristics, all of the studies included were randomized controlled trials published between 1996 to 2016. Follow-ups varied from 4 months to 3 years. These studies were carried out in New Zealand, Korea, USA, Slovenia, and the United Kingdom. The outcome measures evaluated were mainly foot pain and disability, although in some cases, cost effectiveness, blood tests, plantar pressure, and walking ability analysis were also performed. Foot pain was measured in all of the studies, and disability was measured by Rom, Conrad, and Woodburn. Now we are going to present the included studies. Rom and colleagues compared customized foot orthoses, which means prescribed in accordance with each patient's needs, versus simple foot orthosis, which is the same as a placebo being designed to fit the feet and patients but not to hold the foot or control its motion in any way, for 4 months. The results were that pain got better in both groups and disability just improved in the customized foot orthosis group. Conrad and colleagues compare functional foot orthosis, defined as effectiveness of foot orthosis to compare an ability, versus placebo for 36 months. They concluded that there was no improvement in pain, neither disability. James, Goodbone, and colleagues compared customized foot orthosis made by a podiatrist versus non-customized foot orthosis prescribed by a doctor for 30 months. The results were that customized foot orthosis group demonstrated improved pain and disability. Nanson 2, during a 6-month period, all patients wore an extra deep 4-foot rocker shoe with either a custom-made semi-rigid insole or a simple foot orthosis. Pain decreased significantly in both groups, but intergroup comparison showed no significant differences. And the last one, Novak and colleagues compared functional foot orthosis versus simple foot orthosis for 6 months, and both groups showed improvement in their pain. To accurately measure the impact of foot orthosis in terms of pain and disability, and to carry out the meta-analysis, we established 2 types of results. Those obtained in long term, defined as studies with more than 6 months follow-up, and in short-term follow-up, defined as studies with 6 or less months follow-up. Now focusing on pain, short-term studies reported improvement foot pain outcome in patients with foot orthosis, but there was no statistically significant differences between the intervention and control groups. This conclusion was corroborated by our meta-analysis, and with long-term studies reported either statistically significant differences or the differences were noted toward the end of the study. Now focusing on disability, because only 1 article was included in the short-term category, it was not possible to perform a meta-analysis. But with long-term studies, it was reported that in both groups there was statistically significant differences. Those were the results corroborated by our meta-analysis. The risk of bias in the studies selected is presented here, Most studies had low quality in the blinding of participant and personnel, and uncertainty in blending of outcome assessment and attritional bias. Our initial hypothesis was that the use of foot orthoses enhanced disability due to pain reduction and increased mobility in patients with rheumatoid arthritis. However, this current analysis shows no statistically significant differences between use of foot orthoses and other non-pharmacological treatments or placebo group. Also, it's important to keep in mind the small sample size and limited sensitivity of the Foot Function Index questionnaire. Finally, this study concludes that foot orthoses can relieve pain and disability and enhance patients with rheumatoid arthritis, but no statistically significant differences were found between control and intervention groups. Thank you for listening, and if there are any questions, I will be pleased to answer them.
Okay, thank you very much, Ms. Laura Ramos. Due to lack of time, we haven't got questions, but thank you very much and congratulations for your communication. Now I leave you with Gabriel Gijón.
Okay, I'm sorry, but the problem is to record the presentation. If we have 4 hours, and in this time we need to capture the presentation. So, okay, thank you so much. I hope enjoy this morning of the presentations. And 3:30. Yes, 3:30. We continue with the conference. 3. Sorry, I wait a minute because I need to see.
In the program we have at 3 o'clock.
3 o'clock. Okay, I'm sorry. And 3 o'clock we continue with the presentation. It's another link. Don't remember. So, but it's other link that you have. So if you have some problem, you can write. Okay. See you in 1 hour and 45 minutes. Enjoy. Bye bye.